Hi, I am so delighted to meet you in the program of JIP case study. 47 years old male patient, a known type 2 diabetes, came with the complaints of cough for 4 days, high grade fever with shivering for 4 days, and complaints of chest pain increased by breathing for 2 days. And when patient was subjected to routine investigation which revealed leukocytosis and chest x-ray shows opacity in the right middle lobe. So what is your management? So if you look at the case study, on examination, the general examination is unremarkable. Systemic examination, right side, mammary area, crepitations are heard and there is bronchial breathing. So how will you manage this patient? Okay. So when somebody presents with fever and cough and when you are able to hear crepitations and bronchial breathing, I think that it's a very classical sign of consultation. I think that which has correlated well with the X-ray in this patient. Okay. Now we are dealing this patient as a case of pneumonia. So when we say pneumonia, then the treatment starts with how you are going to categorize whether it is a community acquired pneumonia or it is a hospital acquired pneumonia or ventilator associated pneumonia. Why we are supposed to categorize this patient? Because if somebody gets pneumonia from the community rather than during the time of hospitalization, then they harbor different organisms. When somebody gets pneumonia during the time of hospitalization and they harbor different type of organisms. That's why we always try to separate whether it is community acquired pneumonia or hospital acquired pneumonia. So this patient, he doesn't have any history of hospitalization. Of course, he has come from the community directly. So definitely it must be a community acquired pneumonia. So most of the time the community acquired pneumonia is caused by bacteria and virus and fungi, of course. If you take bacteria, and most of the time the organisms are Streptococcus pneumonia. Sometimes you have, suppose if they have a COPD, history of COPD, then probably they may harbor H influenza or Moraxella catarrhalis, like this. So when somebody presents with features of community acquired pneumonia, and then we are trying to separate whether he should be treated as inpatient or he should be treated as an outpatient. When somebody presents with pneumonia, but they have increased respiratory rate more than 30 per minute, or when they have hypotension or age group more than 65 years, then probably these patients generally deserve hospitalization. But when they don't have tachypnea, only fever, they are able to sustain good amount of blood pressure, then this patient can be treated as an OP patient. So when you think that you are dealing with community acquired pneumonia, especially homogeneous consultation, okay, in the X-ray, then for all practical purpose we are dealing with Streptococcus pneumonia. So this patient can be treated with simple amoxicillin 1 gram 3 times daily, or you can give azithromycin 500 milligram daily once, or patient can be treated with doxycycline. Because we are able to witness that sometimes when somebody is diagnosed with the community acquired pneumonia, we are so much indulged to give injection piperacillin or injection meropenem while patients are so stable. Okay. But when you think that you are dealing with community acquired pneumonia, he is stable, this patient can be treated with oral antibiotics alone. Generally, they say that if you think that it is a community acquired pneumonia, then probably you don't need to go for broad spectrum antibiotic, which definitely will promote antibiotic resistance. Suppose if somebody has cough only dry cough, subtle onset, the course is subacute, predominant extrapulmonary symptoms. For example, they may have cough, but they will have undue body pain, okay, and they may have extrapulmonary symptoms. For example, erythema nodosum in the skin, or if you do routine investigation, they may develop anemia, they may have anemia, features of hemolysis, then otitis media. When you have extrapulmonary symptoms more and subacute onset, and if you look at the X-ray, you will have multifocal infiltrate rather than the homogeneous consolidation. When they have multiple infiltrate on both sides of the lung, then probably you can think of atypical pneumonia. That's very, very important. So when you think that atypical pneumonia, then probably the beta-lactam antibiotic like amoxicillin and cephalosporin may not have any role. Because when you suspect atypical pneumonia, these organisms are nothing but Mycoplasma pneumonia, Legionella, okay, and chlamydia. Why they are being called atypical? Because first most important is they lack cell wall. So since they don't have cell wall, the penicillin cephalosporin can't act, because penicillin cephalosporin kills bacteria by only damaging the cell wall. Since all atypical bacteria don't have cell wall, what happened? They cannot act. Okay, that's why when you suspect atypical organism, atypical pneumonia, why we rely on macrolide, something like azithromycin or fluoroquinolones, especially high dose levofloxacin and gemifloxacin and moxifloxacin. The reason, this is the one. When you suspect atypical pneumonia, don't go for beta-lactam antibiotic. This patient should be subjected to either macrolide or quinolones, especially respiratory fluoroquinolones like levofloxacin. So when will you suspect atypical pneumonia? Once again I insist, cough, fever, dry cough, subacute onset, chest X-ray rather than having homogeneous opacity. On both sides of lung, you will have multiple infiltrate, okay. Then you will have predominant extrapulmonary symptom as I described earlier, okay. So when you suspect atypical pneumonia, then the role of macrolides and fluoroquinolones emerges. Otherwise, when you think that it is typical community acquired pneumonia induced by predominantly bacteria, especially Streptococcus pneumonia, then probably you have to introduce more of penicillin like amoxicillin, okay. Sometimes you receive a patient, okay, you receive a patient with all the classical pictures of community acquired pneumonia. They have come from the community, they have homogeneous opacity, okay, but when their age group is more than 65 years, okay, when they harbor CKD or systemic hypertension and cardiac failure, history of alcoholism, taking immunosuppressive therapy and history of malignancy, then probably definitely you have to think of drug resistant pneumococci. That's very, very important, okay. So when they don't have comorbid illness, only community acquired pneumonia and stable patient, probably you can give oral therapy like amoxicillin or monotherapy azithromycin or quinolones. Either one of these can be given. But when they have comorbid illness, as I described earlier, then this patient may harbor drug resistant pneumococci. So this patient deserve one step ahead. So instead of giving amoxicillin, better you can give amoxicillin with clavulanic acid. That is a better choice. When these patient, either community acquired pneumonia, stable patient, okay, without any comorbid illness, or community acquired pneumonia with comorbid illness, but when they become unstable, when they have increased respiratory rate or when they have hypotension, then patient has to be hospitalized, then this patient has to be switched over to IV antibiotic. So IV antibiotic means definitely this patient should be subjected to amoxicillin with clavulanic acid IVBD with one azithro or fluoroquinolones are necessary. When they come as OP stable patient, either one of these drugs, amoxicillin or macrolide or fluoroquinolone, you will choose. But when they become unstable, then you have to switch over to IV, amoxicillin with clavulanic acid. Then you have to add either azithromycin or one fluoroquinolones. That is mandatory. That's very, very important. But you may ask, so many times we introduced piperacillin when somebody presents with pneumonia, when they are hospitalized, immediately we rush for piperacillin, we rush for meropenem, we rush for vancomycin. So is it essential? Please remember that if you strongly suspect this patient only has come from community, never had any hospitalization, then it is community acquired pneumonia. This patient deserve simple amoxicillin with clavulanic acid, or you can go for cephalosporin, either ceftriaxone, or you can go for cefotaxime TDS dose. So where the broad spectrum antibiotic play a major role when you suspect MRSA. For example, if you think that this pneumonia looks like MRSA, or this patient might have acquired infection from the MRSA positive patient. Probably if patient gives history that my mother had been admitted in some other hospital for the management of MRSA pneumonia. So following which patient has acquired infection. So he has come from the home, but he has incurred the infection from the mother who has been treated for MRSA. So when you suspect something like MRSA, so at that time these patient probably prone for getting all kind of broad spectrum antibiotic. For example, MRSA drugs like vancomycin, or you can give linezolid. Then one another cephalosporin has come, that is called ceftaroline. So ceftaroline, the advantage of ceftaroline, the only one important cephalosporin, only I could say it's only one cephalosporin that acts against methicillin resistant Staphylococcus aureus. Usually the drug of choice for MRSA, we used to say always vancomycin, linezolid and daptomycin, and to some extent glindamycin as well. But if you ask, name one cephalosporin which can inhibit your MRSA, then I could say ceftaroline, but it is quite costly. Ceftaroline can act against Streptococcus pneumonia as well. So Streptococcus pneumonia and Staphylococcus aureus also it can act. But what you have to remember that 90% of our community acquired pneumonia is caused by Streptococcus pneumonia, or otherwise called pneumococci. So the Streptococcus pneumonia or pneumococci are very much susceptible to routine amoxicillin with clavulanic acid. But when you suspect drug resistant pneumococci, especially in the case of patients who harbor additional comorbid illness, then probably you may require amoxicillin with clavulanic acid, because clavulanic acid is capable of inhibiting the beta lactamase enzyme produced by these drug resistant pneumococci. That's why we prefer these drugs. I think that you have been enriched with the antibiotic choice. So what I try to insist that always you try to categorize whether it is community acquired pneumonia or hospital acquired pneumonia. Hospital acquired pneumonia means the development of pneumonia 48 hours after hospitalization. Otherwise, if somebody comes from community directly, it is community acquired pneumonia. So for plain community acquired pneumonia, we don't need to go for broad spectrum antibiotic which promote antibiotic resistance. So you can be content with penicillin or macrolide or quinolones. Then probably if patient become unstable, these drugs should be combined. I think that I sincerely hope definitely you have been enriched with few points about management of pneumonia. Thank you.